Can each of you tell us a little bit about yourself and your practice?
Sure. So my name's Tom Salt. I'm a medical doctor, family medicine trained and certified, and I practice primarily something called functional medicine, which is looking for, sort of root cause rather than just treating symptoms. So that's basically what my practice is about.
And Dr. Bruce Feldman, practice called FeldMed. It's really an integrative, holistic internal medicine practice. I trained as an internist, but I've been doing variations on functional medicine for the last 10 years or so.
How do you incorporate the MCG heart scan into your company? And how long ago did you incorporate it?
Probably 10 years ago or more, that somehow I learned about MCG. I think I actually learned about it from a colleague at IFM. And, the truth is that the average person in America will have a heart attack. And a significant percentage of those, the first symptom they'll ever have of cardiovascular disease is a heart attack. And for a significant fraction of those, the first symptom they'll ever have is sudden death. So that's kind of a tough way to get introduced to having a disease. And I've tried various other things, intimal thickness and all kinds of stuff to try to early diagnose and help people understand, the risks and so on. And it turns out that MCG is just really, really good at that. Plus it's reproducible and you can use it over time to determine if what you're doing is the right thing or not. So it turns out to be a really powerful tool for finding people before they have clinically relevant disease and preventing them from progressing to clinically relevant disease.
So I first met Dr. Shen, who's the developer of the MCG, in 2001, and saw the first iterations of, it was pre-MCG. It had a different convoluted name, and an incredibly difficult to read report that actually I found my first report, and it's unintelligible to me even today. I was a medical director. I became the first medical director to approve the MCG for reimbursement back in 2001. I subsequently left medical directorship and went back into primary care practice, and happened to take up an office that was not 1,500 yards from Dr. Shen's Premier Heart office. And I remembered the machine, and I was doing advanced cardiovascular preventive cardiology type stuff. And I went looking for it only to find that it was right literally down the road. So that's when I started back. So 12 years now, I want to say.
That's awesome. Thank you for sharing that. We do have some physicians that ask us occasionally, how long does this last? Is it going to be changing a lot? And, by what Dr. Shen has told us, it sounds like the technology is still there. It's the same it was when you guys first found it, and it maybe the hardware gets a little bit better and the reports get a little easier to read, but it still does the same thing. So when you first were introduced to it, was it a little bit difficult to read the reports, or do you find the reports fairly easy? We have some physicians that are concerned about being able to learn how to read the reports and interpret them to their patients. So what would you tell them about that?
So I actually wrote the interpretation guide with the help, well, Dr. Ranford and I primarily wrote it. He's the chief medical officer for Premier Heart. And we organized that as best we could. The thing that people don't understand, I think, is that unlike conventional sort of by the book medicine, this technology is very sophisticated. This technology does not give you a simple linear response, A plus B equals C. it's more complicated than that because the human system is more complicated than that. So it requires a clinician, it requires an understanding of the patient, and oftentimes there are benefits to, as Tom said, reviewing a situation over time.
Yeah, and what I would add to that is that the MCG is really statistical medicine. And by that, I mean, all of medicine is statistical on some level. You know, just because somebody has a high cholesterol doesn't mean they're going to have a heart attack. And by the way, the majority of people who have a heart attack have normal cholesterol, right? So it's a statistical issue that there is in the case of cholesterol, there's a probably insignificant and meaningless increase in the statistical probability of a heart attack with rising cholesterol. With MCG, we get basically, we get a couple of statistical, well, several actually, statistical models of what might be going on with this person. We can interpret them in various ways. So the first thing we get is an ischemic score. And we can, it goes from 1 to 15, and we can kind of put that into a few different categories.
0 to 22, if you go.
Oh yeah, thank you. 0 to 22, and we can put that into several categories. And those categories,
after 15, it kind of doesn't matter.
Yeah, exactly. After 15, you're sort of, you know, need to be on the table. But in any event, the higher that number is, the more significant the probability, and significantly so, with like better than 90% correlation to angiography. And then there's other pieces you can read into those scores, because we generally do this in a run of 5. And if you're seeing all of the numbers tightly bunched, you know, plus or minus 1, it's a stable lesion. It's some kind of actual blockage. If you see it kind of, you know, spread out greater than plus or minus 1, it suggests that there's probably some spasm. If that smaller number is a high number, they have some spasm on top of a fixed lesion. So there's a lot of things that you can kind of infer and interpret from just that ischemic score. And then there's statistical correlations with all kinds of other cardiovascular issues, like, you know, heart failure and arrhythmia and all kinds of other things that show up on the test. But, you know, the thing we have to remember with statistics is, you know, there are lies, there are damn lies, and then there are statistics, as Mark Twain was famous for saying. And so, you know, we can't be telling our patients, oh, the MCG says you have, you know, heart failure. What we can say is that the algorithm suggests that people with your findings have a higher probability of having heart failure. So I think that's something that really confuses new doctors to the use of MCG, is that it's, you know, it's not like getting an angiogram where the cardiologist says this is the diagnosis. It's the raw data that the physician then needs to interpret with some art.
And a couple of points to that. So realize, of course, that the EKG will reliably miss 80% of those who've already had a heart attack. So you can put a label on it, but it may not apply.
Right.
There was a study out of a bunch of Florida ERs that demonstrated that if you came to the emergency room with chest pain and you scored greater than 4 on any one of those 5, you had a high likelihood of having a cardiac lesion that would be amenable to some sort of intervention, i.e. stent or the like. If you had no such score, then you had 0 chance of having a lesion that was intervenable. That's a huge, statistically significant, clinically relevant piece of data that I know is not broadly out there, but it is the single strongest piece of evidence to support the sort of triage effectiveness of this technology.
So you've kind of mentioned it already, but we get it all the time. Doctors are so used to using the normal EKGs, the echoes, the stress tests. What can you tell them about your experience in switching over from those types of the normal standard of care over to this machine?
I don't know that we want to say that we're switching over.
Right.
There are appropriate times for each of those technologies. Probably, I think I can confidently say, a lot of the time, they are unnecessary in the circumstances that they are utilized. So what I view the MCG as the sort of go-to when you're trying to evaluate a large percentage of the cardiovascular of someone's cardiovascular status. So if I have concerns about arrhythmias, for example, if I do an MCG, it's going to tell me what their electrical instability and the likelihood of disaster is. And then I can look at that and decide, am I going to go further with some sort of event monitor or whatever? If I see that, if somebody comes in with chest pain and they have zeros across the board, I'm going to take a big yawn and say, okay, don't worry, you're not going to die. We'll figure this out. There are a couple of things that I think are important to mention with regards to the reporting. The language is different. So standard cardiology terminology is applied throughout the report. However, the meaning in the report is based upon cellular dynamics and cellular function, not global function. So for example, there's a category of cardiomyopathy. Well, the regular clinician understands what that is. On an MCG, cardiomyopathy means the same thing, only on a microscopic cellular level, so that each individual cell is not squeezing the way it should, let's say. And there are levels of sophistication that differentiate these shifts from normal that then aggregate into bigger problems. So for example, the MCG, we can define a pre-atrial fibrillation condition years before it manifests, which from a clinician perspective becomes a problem, because now, well, what am I going to do about it? And the sensitivities are such that many physicians who have attempted to use this have sort of gone away from it because they, quote unquote, have too many false positives. Well, the technology measures small vessel disease, for example, and there's nothing else that measures small vessel disease like this technology. So we're seeing things. I can give you a great example, okay? I have a guy who I saw last week or the week before who wanted an MCG. He heard me talk about it, and he's a runner. He's done marathons. He's in good shape. He takes care of himself. All those things are nice. Guess what? His MCG comes back with zeros, okay? And his second page comes back with nothing. And his third page comes back with some very interesting things, which isn't going to mean much to you, but Tom will appreciate this. There's myocardial remodeling, there's bradycardia, and there's increased myocardial compliance. Well, here is a measure of cardiac function heretofore unavailable. There is no other test that can demonstrate that this guy's heart has remodeled because he's a runner without pathology.
Mm-hmm.
Another example would be, one of the competing technologies might be a coronary artery calcium score. And the problem is a coronary artery calcium score, a CT score, will only measure calcified plaque. It doesn't measure soft plaque, and it's actually soft plaque that's probably more vulnerable to rupture. So you might have a completely normal appearing CT score and yet an elevated MCG, which would suggest that we need to, if it's high enough, consider going straight to angiography, or if it's lower, considering very aggressive diet and lifestyle interventions.
The thing to realize about an MCG is that it's a physiologic test. It is not an anatomical test, and all the other sort of visualizing technologies are anatomic tests, but they are anatomic tests measuring the negative. So you don't know where it was supposed to be. So it looks like it's this wide, okay? It's this wide, but it's really supposed to be this wide. And unless it's multiple standard deviations from what you would expect, no one's going to call that as abnormal unless it's got a big dip in it. So an elongated plaque will go unnoticed, go unread.
Which is common in women, as an example.
South Asians have congenitally smaller coronary arteries. So they have nice, smooth blood vessels, but they're at higher risk for disease and limiting blood flow, ischemic conditions as a consequence. So there's a whole host of things that you can open your doors to and understand that that's really not available somewhere else.
Excellent. And then when a patient comes in and they're like new to the practice, are you suggesting that they have the test run so that you can get a baseline, or how do you pick the patients that you're going to put through the test?
Well, so there's a lot of ways one could do that. You could look at a Framingham risk stratification. You could do a lot of things. But as I said earlier, the average adult in America is going to have heart disease. And so I'm doing it on everybody, right? New patient comes in, that's part of my screening process, because your heart's kind of a necessary organ.
Yeah, we only get one, right?
You only get one, yeah.
Yeah, I mean, my practice is really varied. People are coming to me for different reasons. If they squeak at all with regard to a cardiac process, it's, the first stop along the way. If anybody was, if somebody wants to talk about cholesterol, I'm going to talk about an MCG.
Right.
And as a consequence, I have people, for example, who have high cholesterols, and you do their MCG and their score is 0, and they're not taking statins and they're not doing any of that other nonsense.
Right.
So if you find a patient that has a score of, say, let's go in the middle, around 6 or 7, what do you do to try to reverse it? Do you put them on a lifestyle change, or, is it optimal medication plus lifestyle change?
So this is where my favorite 2 words come to play. It depends.
Yeah.
So, is the guy diabetic? Is he overweight? Does he exercise like crazy? Is he stressed out? Does he not get enough sleep? I mean, there are all those things, So you've got this checklist of stuff that you've got to check off, right? If the guy's at high risk, and I don't know about you, Tom, but if the guy's at high risk and he makes me uncomfortable, I may send that guy straight to cath.
Mm-hmm.
It doesn't matter, it depends on kind of where they are and why they're coming to you. If they're 6'7" and they're describing episodes of angina or things of anginal equivalence, then I don't screw around with those people. Like Tom said, these guys could die, literally. If they have, there are markers that the MCG points out that put them at dramatically higher risk for things like sudden cardiac death. If they have any of those, they're out of my office. They're in the cath lab as fast as I can get them. And I have guys here on Long Island who we've saved people's lives with the MCG. So I send them to those cardiologists because they know what they found. I had a lady came in one time with, she'd been anxious, according to her therapist and her primary care doctor and all of this sort of stuff. And I talked to her and I thought she had had a heart attack. And we did her MCG, and sure enough, really looks like she had a heart attack. She goes to the cath lab. She gets 2 stents and a third vessel. It was too distal to get stented.
Yeah, it depends. You know, there's the old story about I wish I could find a one-handed lawyer, because on one hand and then on the other hand, right? But it's true. I mean, if somebody comes to my office and they've got chest pain and they've got a score of 6 or 7, I have cardiologists that I work with regularly. They understand what I'm doing and they say, yep, let's go to cath lab. On the other hand, if the guy is otherwise seems stable, he's asymptomatic, maybe he does his own stress test by running and so on, at least he doesn't have overt chest pain, I'm probably going to do aggressive diet and lifestyle, and I'm going to do frequent MCGs to make sure we're not, you know, escalating his symptoms or his MCG score rather than de-escalating it. But that's,
sorry,
I was just going to say, but that has to be done in the context of a partnership, because you need to help these people understand that for many people, the very first symptom of heart disease is a heart attack. And for a percentage of those, the first symptom is sudden cardiac death.
Yeah.
So, you know, if they're willing to move forward in a more conservative way, we do that. But if they say, well, gosh, that sounds terrible, well, I'm sending them to the cardiologist.
Yeah, I mean, if that guy comes in and, you know, there are markers of global
energy failure,
and, you know, they have for the, what is it? Asynchrony, rather. Global asynchrony, and you've got some myocarditis and things like that. I mean, there are metrics that you go, holy cow, I'm not playing with this. Right. You know, but on the other hand, you know, the guy's a diabetic and he's like, you know, he's got small vessel disease, but he has no obvious signs of, active ischemia despite his scores. Those are metabolic measures, right? So when you start having anatomic problems on top of metabolic, that's where it gets hairy. If it's just metabolic, I mean, listen, we did a lady who trains at 12,000 feet, and she's an advanced ICU nurse who works too hard besides, right? So she's out in Colorado. We do her MCG. It's terrible because she's having high altitude problems and she's not resting. And we can see measures of overtraining. So there are levels of information that you just can't get anywhere else.
It's amazing what you know, we utilize the MCG and help physicians understand that, you know, it is next to the angiogram of being non-invasive. It could pick up the small vessel disease for women, which is one of the leading cause that women get misdiagnosed.
You know, there were some early studies, they were small, but there were some early studies that the MCG compared nuclear stress test in women. And the nuclear stress test in women yielded more erroneous results than accurate results. And the MCG was vastly superior across the board. But in women, it was like night and day. I mean, it wasn't even close.
Dr. Feldman, we know that you need to go. And is there anything else that you would like to tell anyone that's looking at getting an MCG for their practice?
You know, I mean, I've been using it for a really long time. I mean, I have a whole host of things that I would like to enhance with the program. I think there are things that we can do. The problem with doing that is it gets more sophisticated. The levels of information that are available are far beyond what the report even gives you. But when you get to layers and layers and layers of stuff, you know, you've got to be very specific in who's seeing that, because it's overwhelming. So that's where you're going to get pushback from like a primary care guy. I just want a yes or no. Well, you know, that's modern medicine today. But, you know, I think we both agree modern medicine needs to change.
Well, thank you so much, Dr. Feldman. If you need to drop off, we understand. And we do appreciate everything you've done for us in helping develop this and get it out to the public. And, Tom, do you have anything else that you'd like to tell physicians?
Well, there is a learning curve to this, as you've probably figured out, but the learning curve is not that bad, mostly because of the work done on the interpretation guide. Once you've done a few and read a few and maybe got a little bit of mentoring with somebody else who's read a few, it's pretty straightforward, but the learning curve isn't nearly as bad as it was 10 or 15 years ago. We have this interpretation guide, which takes a little understanding, but the issue here is that the number one killer in the United States is cardiovascular disease. And the current technologies are insufficient for managing this epidemic of heart disease. So MCG is a sophisticated way of doing very high level preventative care, because we can find vascular disease that is either missed by other technologies or is too distal to be treated with, stents and things like that, or is showing up before it would really be obviously a problem by any other technology. So we can implement, we can show, one of the things that people need is feedback, right? So when we can show them an abnormal test, there's some motivation there that's maybe beyond just, gee, you should eat better. You should eat better. And we're going to do this test again in a couple of months and we'll see if it's improving. And it will improve that quickly.
Yeah, thank you, Dr. So we've noticed that with a lot of patients that we have tested, that, if they do the lifestyle change and what the physician recommends, their scores get better.
Very quickly, yeah.
Amy, do you have any other questions that you'd like to ask Dr. Sultan?
The only question that I have is, when you test a patient, do you do any billing on that patient, or is it just primarily cash pay for them?
I used to have an insurance-based practice. I'm now completely cash. I don't even interact with insurance companies. I don't even make super bills, so it's purely cash in my office.
We know a lot of practices that do it that way.
Right. So we appreciate it again.
Yes,
Thank you.
we do. Thank you so much.
Yeah, well, good luck.
And we will be in touch.
Okay.
All right,
Bye-bye.
thank you. Bye-bye.
Bye-bye.
Bye.